So first of all, it's a great honor, of course, to be a part of this IC with so many well-known and experienced surgeons. And of course, it goes without saying that it's a humbling experience to work and to sort of learn from Dr. Grover. So that's a great thing for me, and definitely to be here with Dr. Mukesh, Dr. Shalu, and one of my role models, Dr. Kasturi. Thank you very much for having me. So I'll be talking about congenital nasolacrimal duct obstructions, and I'll be covering the talk in these headings. So most children, even if they have it, only 20% of them actually present with it.
Can you start your screen share, please?
Okay. Oh, it's not started? Okay, sorry. Right. Can you see it now?
Yes.
Right. Okay. So 20% of them in the first year of life, they present with the watering, and 80 to 96% of them resolve spontaneously by the first year. So just in brief, the nasolacrimal groove is formed after 6 weeks, and the floor of the nasolacrimal groove gets an ectodermal cord, which sort of starts canalizing at about 4 months of life. And this gets completed at birth or within the first few weeks after birth. So there are various causes of nasolacrimal duct obstruction in children. One is the membranous block at the valve of Hasner, which is the most common, or stenosis from a narrow NLD at the inferior meatus, or a hypertrophied inferior turbinate and bony abnormalities as they grow older. So the common symptoms and signs are epiphora, discharge, matting of lashes, skin maceration, and regurgitation when they press over the sac area. Other things which need to be ruled out when children present with watering is eyelid conditions such as blepharitis, congenital entropion, epiblepharon, or conjunctivitis, foreign bodies, corneal abrasions, keratitis, rarely uveitis, and congenital glaucoma. So on examination, definitely there you generally do find a regurgitation or pressure over the lacrimal sac. However, they can also just present with a raised tear.
Your connection, Rituja. Again, can we try the remedy of switching off your camera?
Okay.
Try again. Now we can hear you. Yeah. Go on.
Yeah. Can you hear now?
Okay.
Yeah. Yes.
But we are not seeing your screen.
Right.
Yes.
Share your screen.
Yeah, I think they stopped my share. Yeah, I'll just share it now. Right. Can you hear now?
Yes.
Okay. And in some of the older children, syringing can be performed. However, this is usually discouraged as it can lead to canalicular stenosis and things like that later. One of the conditions which warrants an imaging is Dacryo which can also sort of have respiratory obstruction at birth. So it's important that these undergo imaging. Apart from that, patients with Down syndrome commonly develop nasolacrimal duct obstructions and craniofacial malformations. So an imaging is warranted in such cases. So spontaneous resolution, the rate definitely decreases as the child nears 1 year of age, but definitely it is highest at 1 month to 3 months. After 12 months of age, you can see that it sort of declines sharply and then plateaus. And the rate of resolution after 12 months is quite low. So we can manage these patients conservatively as well as surgically. So in conservative management, hydrostatic massage and topical antibiotics have classically been advised. However, we need to shift over from calling it a massage to a sac compression. So this hydrostatic sac compression is what we need to explain properly to the parents, give a proper technique, and educate the mother well Something which I had seen earlier during our subspecialty days, Dr. Akshay had spoken about, giving a WhatsApp video to the mothers to sort of reiterate how the compression is done. So that would be a very good addition to our armamentarium of trying to get these patients to respond well to conservative therapy. So NLDO can be generally watched for a year unless it is complicated by other factors such as skin maceration or any other complex forms. So amongst invasive therapies, the first line is definitely probing along with the syringing. And the second line would be repeat probing, silicone intubation, balloon dilatation, and a DCR, whether external or endoscopic. So with respect to probing, we generally can wait for 12 months to probe. However, certain conditions such as Dacryo, you can probe them early, and it can be delayed up to 4 to 8 years. So the technique involves nasal packing, good examination, meticulous technique for passage of the probe, and confirmation of the patency with a syringing. And it is done under general anesthesia. So first, the upper punctum is dilated, a probe is passed, and the direction is sort of initially medially, and then downwards and posteriorly, and then laterally at the very end. So this is an example in an adult cadaver of exactly how the position of the probe is and the direction of the nasolacrimal duct. So with respect to the success rates of probing, definitely it's good up to 12 months, but then again after 12 months, it starts to decline. So the sooner you can do it after 12 months, the better. And there's a difference between the success rate of the first and the second probing. The second probing also has much lower success rates than the first probing. So post procedure, we should advise them topical steroid antibiotic drops. There are studies on the efficacy of tobramycin, dexamethasone, and you can use any similar kind of steroid antibiotic combination. And what we found is that steroid nasal sprays and decongestants initially also help keeping them open. Some complications are bleeding. Bleeding is usually due to a false passage, and inability to pass the probe down to the NLD, sometimes entry into the submucosa of the lateral wall, and of course, failure. So a failed probing could be because of an improper technique or a bony obstruction or inflammation with age. So the more older the child is, the more inflammation they've had in their canaliculi over the months. So that is one of the reasons. And there are anatomical variations, such as buried probe, impacted inferior turbinate going to the anterior end of the inferior turbinate and the maxillary wall. So a failed probing can be managed, as I've mentioned before, by a repeat probing or an inferior turbinate infracture or silicone intubation or a DCR after 4 years. So inferior turbinate infracture, again, the same preparation is done. And a periosteal elevator is sort of passed under visualization beyond the inferior turbinate, and the inferior turbinate is lifted, and you generally hear a cracking sound at the end of the procedure. Again, after this, you do confirm patency via syringing. Now, intubation can be monocanalicular or bicanalicular. Most commonly, a minimonica is used or a Rittling procedure is done, again under visualization. So it's usually done for failed probing and can be done along with the DCR as well. The problems you may face are securing a passage, having discharge post-operatively, and extrusion of the tube. So with respect to monocanalicular versus bicanalicular, they have been pretty similar in their success and dislocation rates. So you can opt for either. Another option is balloon dacryoplasty. So it can be a primary procedure after 12 months in whom probing has failed also, or silicone intubation has also failed, and it has a pretty good success rate. So what is done is basically a balloon catheter is passed in the same direction as we pass the probe, and it is inflated to about 8 atmospheres initially for 90 seconds, then deflated, then 60 seconds and deflated, and then 90-60 repeated. So it has a good dilation, and since the foci of the balloon are radial, they don't really produce any tears or anything, and it is a little less invasive than probing or silicone intubation and can be repeated safely. Now, endoscopic assisted probing is probably something which people are opting for a little more these days, and it permits the direct visualization of the probe at the lower end of the nasolacrimal duct. When you're not visualizing it, yes, you do a metal on metal contact with your periosteal elevator, but in this you can directly see and go ahead with any other procedures if you feel need to be done, such as inferior turbinate infracture. Dacryo rhinostomy generally preferred in patients who are 5 years or older, in unresolved nasolacrimal duct obstructions who have undergone multiple procedures. It can be done in external or endonasal form. However, there are certain issues with respect to the anatomy in inexperienced hands, and they can be prone to more scarring. So definitely mitomycin C is a very good idea in children, and most surgeons opt to do a stenting at the end of the procedure. So a newer modality which has been found is the Dacryo Endoscopy. So in this, a Dacryo endoscope is used to sort of visualize the anatomy right away, and then a bicanalicular stent is placed, and this group sort of found that they had 100% success rate. So this could be something worthwhile if we can start off in future for ourselves. So this was an important sort of study or survey which was carried out by Dr. Akshay Nair's group, wherein most of them advised sac compression up to 1 year of age. And 2 years was the age limit for their sac compression, and 1 year was the minimum age for advising probing. The upper age for age limit for probing being 5 years, and younger surgeons such as myself were probably more likely to offer a trial of primary probing in children between 8 to 12 years. And 50% have started using nasal endoscopes during probing, and 32% for intubation. And 81% would rather repeat the NLD probing with adjunctive procedures over a dacryo-rhinostomy. So this is just a basic outline of my talk. So when there is CNLDO related epiphora, you can do a Krigler lacrimal sac compression and observe. If it's a complicated one, you can do probing under 12 months. If it's a non-resolving simple one, you can go for probing. And if probing fails, repeat probing with inferior turbinate fracture, intubation, balloon dacryoplasty, and multiple procedures fail, or there's dacryocystitis or bony obstruction, after 4 years of age, you can do a DCR with intubation. Thank you for your patient listening.